everyone once again. So today my topic for discussion is IUI tips and tricks. Mostly I'll be covering the practical things and clinical aspects of it. I'll not be going deep into the theory part. So IUI, intrauterine insemination, it's an assisted conception technique involving the deposition of processed semen sample in the upper uterine cavity, overcoming the natural barriers to sperm ascent in the female reproductive tract. So, what is the rationale of IUI? Rationale of IUI is to increase the gamete density, both oocytes and sperm at the fertilization site, to bypass the cervical and sperm abnormality, and so that we can increase the likelihood of pregnancy. Then optimizing IUI outcomes in clinical practice. This is very important for the gynecologists in infertility care, because in your OPD, you'll be seeing a lot of patients with PCO, with unexplained infertility, for whom the basic or the first line treatment will be ovulation induction, and later on IUI is the next step of treatment. So at level 1 ART, it is a level 1 ART treatment. So I'll be talking a little bit about the evolution of IUI. So initially, when we have started doing IUI, when the clinicians started doing IUI, initially they were doing for couples wherein there is a male factor disability, like a physical or psychological disability, they were doing IUI. Then in donor IUIs, only they were doing in patients with azoospermia or very low sperm count, or a husband with a Y-linked genetic diseases. So initially they were doing only for these indications. And then later on, now we are doing it for all the mild male factor infertility and unexplained infertility also, we offer IUI treatment. Then when the clinicians are nicely doing the IUIs in their OPD, there comes NICE guidelines in 2013, where the NICE guidelines recommended IUI not to be routinely recommended. And what they recommended is 2 years of expected management, and when the couples don't conceive, then do IVF. So once these guidelines came up, then the UK government or the insurance companies stopped funding for IUIs, as these fertility treatments were insured in other countries. But after these guidelines also, many of the clinicians still practiced IUI. 96% clinicians still offered IUI. According to those NICE guidelines, IUI is allowed only for intercourse disability or a HIV positive discordant couple, or in the same sex couple. Only these indications they allowed for IUI. So there was a problem, because the clinicians are advising IUI and the insurance companies, they are not covering the IUI procedures. So then later on, there is a re-emergence of IUI. In 2016, the expert defended IUI as cost-effective and evidence-based treatment. In 2016, Professor Homburg and Bahadur et al., they published an article in Human Reproduction strongly favoring IUI as first-line treatment option for subfertility. And in 2017, there was an RCT presented at ESHRE by Cindy et al., which showed the live birth rate of 31% in IUI versus 9% in expected management in 3 cycles. So this editorial by Professor Omelette, this is the turning point, where he stated that if the tubes are open in a female, there is no reason to avoid IUI. So he also stated that IVF ICSI is overused in the mild male factor or unexplained infertility, in which cases IUI should be the first line of management. So that is about the brief history on IUI. Then coming to the indications of IUI, the female factor and male factor. In female, ovulatory dysfunction, endometriosis minimal and mild, then cervical factor. In male, mild male subfertility, then ejaculatory failure like hypospadiasis, neurological like spinal cord injury, retrograde ejaculation, then psychological, that is impotence. These are the other indications wherein we advise IUI: unexplained infertility, HIV discordant couples, or the other infections like hepatitis B, HCV, where the one partner is positive and one partner is negative. To avoid the sexual intercourse, we process the semen sample, we wash the semen sample so that the transmission of infection is reduced. Then it is also considered while waiting for IVF or in women with patent tubes when IVF is not affordable. Then IUI donor indications, when there is a gross male subfertility like azoospermia, severe oligoasthenoteratospermia when the couple is not affordable for IVF ICSI. Then HIV discordant couples where the to reduce that minimal transmission of infection with IUI, they can opt for donor IUI. Then familial or genetic disorders in male, severe RH incompatibility, then single women and single sex couples. All these indications we can offer IUI donor. Then coming to contraindications, damage to or a blockage of both the fallopian tubes, severe pelvic endometriosis stage 3 or above, wherein the tubo-ovarian relationship is disturbed, then peritubal adhesions, severe male factor infertility, then active genital tract infection, cervical atresia, unexplained uterine bleeding. These are all contraindications of IUI. Then coming to the protocols and monitoring. So in IUI, we aim to develop follicles in ovulatory cycles and anovulatory cycles, as in PCOS and in hypogonadotropic hypogonadism. So in IUI, what is our aim? In anovulatory, like in PCO, where they are not ovulating, our aim is to develop at least a single dominant follicle by ovarian stimulation. In hypogonadotropic hypogonadism also, usually as there is a disturbance in HPO axis, they do not ovulate on their own. So they need hormonal support or exogenous hormones for the follicle to develop and for ovulation. Whereas in patients who are already ovulating, that is a normal menstrual cycle, regular menstrual cycle, already ovulating women, we aim super ovulation, that is development of more than one follicle and ovulation of more than one follicle. So that is a super ovulation. So we can stimulate an IUI cycle by using oral ovulagents or injectable gonadotropins. So stimulation we can do with the oral ovulagents like letrozole, clomiphene citrate or tamoxifen, with or without gonadotropins, and a low dose gonadotropins. Only low dose gonadotropins can be used to stimulate an IUI cycle. Then coming to the protocols, there is one natural cycle IUI wherein we don't stimulate the patient at all. We just monitor natural cycle of a patient. This can be done only in the patients who are regularly ovulating. So we just monitor the cycle. So we call the patient on a day 2 or day 3 for a baseline scan, and then depending on the cycle length of the woman. So we call her again to see the follicle, dominant follicle, and once we see a dominant follicle of more than 16 mm, then we'll ask the patient to monitor or to check the urine LH, kits. And whenever the surge has started, we plan the IUI depending on the LH surge. So we don't trigger also in this, as it is a pure natural cycle. So is there any use of a natural cycle IUI? So most authors or feel the natural cycle is not very useful and the pregnancy rates are not very high when compared with the stimulated cycle. Only in the natural, at least in the patients with unexplained infertility, only in patients where we are doing donor IUIs, we can do a natural cycle wherein the female partner is all okay, only the problem is the sperm. Then we can try a natural cycle IUI and we can also prevent multiple pregnancies with this protocol. Then coming to the stimulation, ovarian stimulation, we can do it with the oral ovulations. So most commonly used nowadays is the letrozole. So letrozole, it's an aromatase inhibitor. It acts by inhibiting aromatase, which converts androgens to estrogen. So it decreases the levels of estrogen in the body. So which reduces the negative feedback on the HPO axis. So thereby increasing the gonadotropin releasing hormone, and gonadotropins, the increased concentration is increased. Thereby, these gonadotropins stimulate the ovary to develop follicles. So here with letrozole, the concentration of androgens is also increased inside the follicles. Intrafollicular androgen concentration is increased. So this will increase the sensitivity of the follicle also to FSH and the sensitivity of receptors, and the receptors of FSH receptors are also increased on the follicle. So this low levels of E2 and increased FSH and increased concentration of FSH receptors and more concentration of intrafollicular androgens, all these will induce mostly a monofollicular growth in the patient. So mostly it is a first line drug for ovulation induction or IUI in PCO patients. So usually the dose, the first when a patient comes, so we can start with 2.5 mg letrozole once daily. If the patient has not used any sort of ovulation induction prior, we can start with 2.5 mg once daily or 2.5 mg twice daily. If the patient is obese, we can start with 2.5 mg twice daily and then for 5 days from day 2 to day 5, and then check her scan for a selection of follicle after 1 week. That is on day 7 we can see. So the next drug is clomiphene citrate. So clomiphene citrate, it is a selective estrogen receptor modulator. So it acts by blocking the estrogen receptors on the hypothalamus. So the hypothalamus, negative feedback of estrogen on the hypothalamus is reduced, and then increasing the gonadotropin releasing hormone, and the gonadotropins are increased. So the clomiphene citrate, it has an anti-estrogenic effect on the endometrium. So most of the patients with clomiphene citrate so they have a thin endometrium because of this anti-estrogenic effects. The dosage of clomiphene citrate is, we can give 50 mg to 100 mg per day for 5 days, and the maximum dosage is 150 mg per day can be used for 5 days. And if the clomiphene citrate, if the patient is on clomiphene citrate for 3 cycles and the patient is ovulating and still the pregnancy, patient didn't conceive, then we call it as clomiphene failure. Then whereas with the high dose, 150 mg maximum dose of clomiphene citrate per day for 5 days and at least 3 cycles, and the patient has not developed a dominant follicle or ovulated, then we call it as a clomiphene resistance. So the next drug is tamoxifen. So tamoxifen again is, the mechanism of action is the same. It is selective estrogen receptor modulator, but this has a agonist action at the endometrium, estrogen agonist action. So it will not cause the thin endometrium. It will increase the thickness of endometrium. So whenever a patient is having thin endometrium with letrozole or clomiphene citrate, tamoxifen can be used to get a good endometrial thickness. Then comes the gonadotropins. So gonadotropins, along with the oral oval agents, we can add 1 or 2 doses of gonadotropins. Or there is another protocols wherein we use only the gonadotropins to stimulate. So these are the regimens wherein we use low dose gonadotropins for IUI in unexplained infertility patients. There is this constant dose gonadotropins wherein we give same dose daily, low dose of gonadotropins daily, and then monitor her ultrasound. And then till the trigger, we give the same dose of gonadotropins. There is this step up protocol wherein we start with a very low dose of gonadotropins. We give it for 5 days, checks the scan, and if we don't see any follicle more than 10 mm, then we increase the dose by 37.5 international units, and then again monitor her scan. And if we don't see any dominant follicle or a selection happen, then we again increase till the, and if there is any dominant follicle, we continue that dose till the trigger. Then there is this step down protocol wherein we start with a higher dose of gonadotropins for 5 days, and then we check the scan, and if we see a dominant follicle or a follicle of at least more than 10 mm, then we decrease the dose slightly and then continue that dose till a dominant follicle is there till the trigger. So the step down is more physiological in a way that it is close to the natural cycle or physiological levels of FSH. In the initial days, the FSH levels are high physiologically, and then once a follicle starts developing and the estrogen levels are increasing, that will cause the negative feedback, and that will decrease the FSH levels, and then this same the follicle which has already grown, it will be gonadotropin independent, so that it will grow on its own and the other follicles don't develop. So risk of multiple pregnancies or OHSs will be less in this protocol, whereas in step up, more cancellations are seen because once we don't see any follicle developing, then when we increase the dose, sometimes more follicles develop at the same time. Many follicles come up when we increase the dose. So then we have to cancel the cycle. So in all these protocols, we do USG monitoring, and then we repeat the scan, and then whenever there is a dominant follicle, we trigger. So when is the IUI done? When the urine LH test is positive, IUI is done 24 to 36 hours later. Or when the trigger is given, like HCG 5000, IUI is done 40 to 48 hours later. So with gonadotropins use, there is a chance of multiple pregnancy and OHSs when a high dose of gonadotropins are used. So usually use low doses, that is less than 75 or maximum 75 units of gonadotropins. Then in poor responders, you can use up to 100 to 150 units to avoid multiple pregnancy and OHSs risk. Then this question, this will be asked by most of our patients. And also you'll be also having the same doubt why the IUI success is limited. Since its inception, since it's when birth, IUI has the same success rate, almost same success rate, whereas IVF success rates have improved to almost 60%. The IUI success rate is the same, almost it is around 20% is the maximum. It will be like 15 to 18% in all most of the centers. So what we are not seeing in IUI, IUI is blind to oocyte pickup by fallopian tubes. That is, whenever the ovulation happens, the oocyte should be picked up by the fallopian tube. So we don't know whether the fallopian tubes are doing that. Then fertilization, whether is sperm reaching the oocyte. or the early embryo development. All these we cannot see in an IUI process. So the success rate will remain the same. So here, this is where the ovulation is happening. The tube has to pick up the oocyte. The sperm has to reach the oocyte, fertilize the oocyte, and then the embryo development has to take place. All these transportation should be properly done by the fallopian tube microcilia, and the embryo has to reach the endometrium. The endometrium should be ready to accept the embryo for implantation. So, timing of IUI is very crucial. So, I'll be dealing some facts associated with the sperm and the oocyte. The facts associated with semen collection, wash, and insemination. So, in IUI, when we remove the seminal plasma, it initiates the sperm capacitation by changes in the ions in the acrosome. So, the processed sperm is viable only 2 to 3 hours post washing. There is no sperm reservoir in cervical mucus in IUI, whereas in the natural cycles, in the natural intercourse, there is a sperm reservoir in the cervical mucus, and the sperm can live in the female genital tract or reproductive tract for at least 4 to 5 days. Whereas in this, as we are removing the seminal plasma and the capacitation has already started, there is no sperm reservoir. So only 2 to 3 hours they'll be viable. So the precise timing of IUI will be crucial. Then the facts associated with the timing of ovulation. This is a WHO probate analysis where they have analyzed a lot of patients in the natural cycles and they have come up with these conclusions. The ovulation happens 24 to 56 hours after the onset of LH surge. The ovulation after 36 hours and sequential over several hours up to 48 hours after HCG injection. So after a LH surge, it happens 24 to 56 hours in between these. And then after HCG trigger, 36 hours to 48 hours. And the oocytes are viable only 12 to 16 hours post ovulation. And after ovulation, if they don't connect with their counterpart, sperm, then they start disintegrating. So the precise timing of IUI is crucial. So the timing of IUI, when to do a IUI. So you have seen a urinary search, then IUI can be done after 24 to 36 hours. Then when you trigger a patient, you can do an IUI after 42 to 48 hours. So here the logic is the oocyte will be viable for 12 to 16 hours at least after ovulation, whereas the sperm is only for 3 hours. So immediately after ovulation, we can do an IUI, which will have increased chances of pregnancy. And also the single IUI per cycle is sufficient and double IUI has no proven benefit. So these are some of the important points. This I have taken it from Human Reproduction Update 2018. So these are global guidelines for a good practice of IUI, where they have done a review and a systematic analysis of all the evidence on IUI, and they have given some recommendation. These are some of the important recommendations. So what is the optimal number of inseminations per cycle? In both unexplained and male infertility, there is insufficient evidence that a double IUI within the same cycle will lead to better pregnancy rates than a single IUI within a cycle. So a double IUI is not very useful. So is there any benefit of bed rest after IUI? So women undergoing IUI should have 10 to 15 minutes of bed rest after an insemination. This has moderate evidence suggesting a bed rest of 10 to 15 minutes. So what is the ultimate number of consecutive IUI cycles per couple or woman in which pregnancy rates still increase significantly? So in couples with an indication for IUI, at least 3 consecutive IUI cycles should be performed. So with semen preparation techniques, results in better or good pregnancy rates, which has best results in pregnancy rates for IUI. According to the available evidence, it is not possible to recommend any semen preparation techniques over another. So all have the same pregnancy rates. Then, what is the cost effectiveness of IUI versus IVF ICSI in couples with unexplained infertility and in men with the total motile sperm concentration of more than 10 millions? At least 3 cycles of IUI is the most effective option. So, then endometrial thickness in IUI. So, most of the gynecologists will be cancelling or adding estrogen when the endometrium is thin in a IUI cycle. So, this recent systemic review and meta analysis on pre ovulatory endometrial thickness in IUI treatment was done by Weiss et al. In 2017. They have pooled 7 relevant studies and they have compared clomiphene citrate and gonadotropins. They have seen that the endometrial thickness is less in the clomiphene citrate cycle when compared to gonadotropins, but the pregnancy rates, there was no statistical significance or difference, which concluded that the endometrial thickness is not a good prognostic factor for IUI treatment success. So the practical points are the bed rest 10 to 15 minutes post insemination is helpful. At least 3 consecutive IUI cycles before switching to IVF in patients where in couples with good prognosis, no strong evidence for more than 6 cycles of IUI. So, because of its cost effectiveness, and in couples where the post-was motile sperm count is more than 10 millions, IUI can be offered. Then the pregnancy rate should always be explained to couples prior. So there are some ongoing controversies like a risk of multiple pregnancies with gonadotropins, whether to use oral ovulagens or oral ovulagens plus gonadotropins or only gonadotropins. So always see the cost to the patient, because with the success rate of IUI, we should try to reduce the cost of the cycle to the patient. So antagonist in IUI cycle is one more, adding the cost to the patient. Most of them, gynecologists will be adding antagonist whenever they see a premature LH surge. So already there is a follicle, dominant follicle, and the endometrium is thin. So to prevent LH surge, they'll be adding antagonist. And we have seen that the endometrial thickness is not a good prognostic factor for pregnancy rates or success rates in IUI. So need not add. You can add antagonist to avoid a weakened IUI, but that will also add a cost to the patient. So always think you are adding the cost whenever you are adding any drugs. Then when do we cancel a cycle, IUI cycle? So IUI cycle we cancel whenever more than 3 dominant follicles are seen, or whenever more number of intermediate follicles are seen, more than 6 intermediate follicles, more than 12 mm. If we see 6 follicles more than 12 mm, we need to cancel the cycle. And then depending on the estrogen levels also, we can cancel cycle. Whenever E2 levels are very high, more than 1000, we can cancel the cycle to avoid multiple pregnancy and OHSS. We can give an agonist trigger and counsel no intercourse or abstinence to avoid OHSS and multiple pregnancy. Or otherwise, you need not give the trigger, just cancel the cycle. And abstinence is very important. Then key factors to improve success rates. The first factor is the patient selection. The age, especially the female age, the duration of infertility, the cause of infertility, the appropriate diagnosis should be made. Then offer controlled ovarian stimulation, follow a right protocol, give the surrogate LH, that is a trigger, at the right time, and plan your IUI treatments. Then a proper semen processing is also equally important. and timing of IUI should be planned soon after ovulation for better success rates. Then the luteal phase support. Luteal phase support, is it required or not required? As we are stimulating the ovaries, we are iatrogenetically disrupting the HPO axis. There will be a supraphysiological levels of E2, and also there will be a shortening of follicular phase and also the luteal phase. So, which needs a luteal phase support, which progesterone we can given, oral progesterone or vaginal progesterone can be given. Then key take-home messages. IUI plus ovarian stimulation is cost-effective for unexplained and mild male factor infertility. IVF fixing is not justified as first line. Patient selection, monitoring, and timing will increase the success rates. Thank you. So, anybody has any questions?